administered the reversal agent if you have given non-depolarizing muscle relaxants. The breathing is regular, spontaneous with adequate tidal volume. The SpO2 is maintained more than 97%. There is return of airway reflexes and muscle tone, which can be seen by the child folding his legs and moving his hands. At the same time, one should be careful that no laryngospasm is produced. This is which is most likely to occur when you extubate the child mid anesthesia. The supraglottic airway devices are easier to place for an occasional pediatric care provider. It is less stimulating and less traumatic. It can be used as an intubation aid as well as a rescue device. However, one should keep in mind that the seating of LMA may be problematic, especially in children who have large tonsils, and they easily malposition in babies who are less than 1 year of age. It is recommended that supraglottic airway device is introduced partially inflated using a rotational technique or a lateral technique in view of the large tongue. Laryngospasm is also very likely with supraglottic airway device, especially if they are removed in mid-plane of anesthesia. Both first and second generation supraglottic devices are available. The size of the supraglottic device is based on the weight. You can also assess the size to be introduced by comparing the size of the mask with that of the ear, the cushion